Thank you. I'm going to go through a few things which I've actually come across when I've dealt with patients from your side. So it's not going to be going through the same things which you can read in textbooks. I have to start by showing this because all of you love this figure of clotting cascade, of course. And you remember this in your sleep. The interesting thing is, and it would be good to know that this is superseded because it's not true anymore. And this is what is the accepted model, which only probably I have to know, but I do have to know this. Marco Ranucci had actually written a recent review on this, and he went through the 7 mechanisms which causes bleeding in patients undergoing cardiac surgery. And I'm not going to go through all this because, again, it's written in the review. What I found surprising here is that although there's thrombin generation mentioned as number 6, there is no mention of coagulation factors in any of this. I don't know whether it was intentional or whether he actually meant that in a different way, but that's quite surprising, and I got a reason why I picked this up. This is a cartoon of how bleeding stops. The latest textbook which came out last year is 2,600 pages, and this is one cartoon summarizing that 2,600 pages. So I'll try my best. So we got 1 Willebrand factor, which is coiled in the subendothelial region, and when you have an endothelial injury, the platelets which is floating past actually gets caught by 1 Willebrand factor. But before that, something which people always forget, the first thing which happens to stop bleeding is vasoconstriction. And nobody thinks about it, including hematologists. The reason why, because we can't measure it, as far as I know, and it's very difficult to prove that as a reason for bleeding. But there's something which I have to be very careful when I say that sometimes the bleeding could be surgical. So if you've got an open...
To get started now,
so
I think this is...
Second step is actually the 1 Willebrand
the most extraordinary title, to be honest. Universal necessity or inappropriate expense. I've never seen saving young people as an inappropriate expense.
And then form a blood clot or fibrin clot. And to make sure that the clot is not increasing in size, it causes fibrinolysis. So if you actually look at all these 5 different steps, what people generally think about is platelets. They think about clotting factors, including fibrinogen. I think in cardiac surgery or cardiac anaesthetists, is pretty aware of fibrinolysis. But what I think people don't always think about is vasoconstriction. And 1 Willebrand factor is never mentioned in any of the reviews I've ever read.
There's absolutely no evidence.
I know that most of you don't do clotting screen, but this is a fairly old slide. But I wanted to actually tell you something, because there are some places they still use PT and APTT, but I just want to use this as an example. PT and APTT actually measures when the clot has started forming. So they actually only measure up till here. The thrombin generation, which is a clot formation, is actually not measured at all by PT and APTT. So of course we now use viscoelastic testing, although it actually measures that thrombin generations in much more detail than PT and APTT. I think that it's not yet the complete test, but it's miles better than clotting screen, but it's not yet a complete test, because I don't think it actually measures the vasoconstriction. I certainly know that it can actually measure 1 Willebrand factor. And 1 Willebrand factor, the reason why it's relevant is because if you actually measure 1 Willebrand factor in most of your patients, it will be about 4 to 10 times more than in the normal state.
That's undergoing,
so it actually
your results with emergent bedside ECMO for having a live patient are better.
Now, there are certain dictums in cardiac surgery. Dilution of clotting factors is a common problem for bleeding. There's an interesting work which has been published about 4 years ago. They looked at a patient whose factor 2 or prothrombin was actually artificially reduced. This is the middle one is people who have got normal clotting factors, and the last one is actually when the plasma was diluted to 40% of normal. And they measured thrombin generation. This can be done actually in vitro in the laboratory, and it's surprising that actually thrombin generation is better than normal controls in people who have diluted plasma. This is in vitro, and I know that it's not easy to actually translate that into practice, but this is surprising compared to actually if you reduce the factor, the prothrombin, the thrombin generating particle much less. And the reason I think is because when you actually lose a lot of clotting factors, or you actually dilute the clotting factors, the other thing which happens is there's a balance between clotting factors and anti-clotting factors. And the anti-clotting factors is also diluted. So what I would suggest is what is happening in many of your patients is that, yes, all these three things go down, which you know it does happen, but these things which is not routinely measured also goes down. So there is a balance still there. So it's something which we need to bear in mind. And dilution, I don't think it's a major problem. Yes, it can be an issue, but I don't think it's a major problem. The other thing is, of course, you're losing a huge amount of blood. So if you open a pipe and all the clotting factors is lost, of course, you don't have the clotting components to start the clot. And again, people looked at thrombin generation, and those take warfarin controls. And of course, trauma is the typical model for massive blood loss. And again, in the initial stages, and I stress, in the initial stages, the thrombin generation was much higher. This makes sense because if you actually started hemorrhaging, what does your body try to do is to actually make lots of clot. But that's in the initial stages. But it can actually activate fibrinolysis and antifibrinolysis later. So just to summarize about in certain cases where people might do routine tests, this is the latest guidance from British Journal of Anesthesia. Clotting screens were not designed to measure bleeding before or during procedures. I still tell every surgeon, but they still do. We had 2,000 clotting screens done in 1 week in our hospital. I can tell you less than 10 of them, 10 out of 2,000 will be necessary anyway. If no other tests are available, you have to think about the whole world rather than the best hospitals in the UK and Europe or US. If you want to do it, you have to actually check the trends. So if the PT and APT is actually started getting worse, that's more important than just one absolute number. This trigger, I mean, I still get this 1.5 times normal, completely baseless. If you want to do something, you have to do it when the patient's PT and APT is abnormal, not 1.5 times abnormal. Now, I want to put something provocative. There are lots of algorithms which uses R-time or CT in ROTAM or TEG. Have you got any evidence to say that by correcting the R-time or the CT, you will actually make the patient's outcome better and they'll bleed less? I do not know, but I'm skeptical purely on the basis that by giving FFP to correct clotting doesn't make anybody bleed less. So I've said about the in vitro data and some ideas. This is a review which I think Sibyl works with Klaus. She again very prolific with her work. This is looking at the effectiveness of FFP, comparing it fibrinogen concentrate, but they also compared with other things as well. Now, I wouldn't go into too much detail except to say that red usually means bad, and if you give FFP, a lot of trials. This is all the trials currently published, and there are a lot of situations where FFP actually was associated with worse outcome. It was associated with benefit in some trials, but in general, it was either not good or no difference compared to the other comparators. And they've looked at blood loss, the need for transfusion, survival, length of stay in the hospital. I'll come to fibrinogen in a second. They also compared FFP versus the other standard volume replacing agents like crystalloids, colloids, or no FFP. In that case, it was much worse, as you would expect. So, if it is in clotting factors, I said, and what is actually the one which will help? And my view is it's fibrinogen, because the most important thing to actually stop a form of blood clot is fibrinogen. And you form this nice cross-linking, and if you think a blood clot forms a mesh, and that's caused by fibrinogen converting to fibrin. And again, there are quite a few papers now on this, and in cardiothoracic surgery as well, and they've shown that if you actually take a target of 2 to 2.5 grams per liter, if the fibrinogen level is less than that, you've got more blood loss in total, exceeding 1,000 mils, re-exploration rate, and everything is actually much worse if your fibrinogen is less than 2 to 2.5. And this is where that actually is very nicely shown. I'm sorry that some of you may not be able to see, but you can see 2 seems to be the magic number. And this is actually being translated to the other massive blood loss situations, postpartum hemorrhage. We've just written the the new guideline, which suggests that we should actually target a fibrinogen level of at least 2. The previous guideline says, well, the old one said 1. We tried to change it to 1.5, and I think 2 should be the ideal mark. And again, you can see the amount of blood product transfusions is completely different in patients who required, whose fibrinogen at baseline was more than 2 or less than 2. And again, if you look here, in short, there's no red blocks, so there's no poor outcome, and you can see lots of green tape rows, which means that the benefit is much more with fibrinogen. Of course, I could go into detail about each one of them, but it's similar to the ones which is done with FFP. So, summarizing what I've just gone through at the moment, early fibrinogen is key to the, of course, fibrinogen is the coagulation factor, factor number 1. So, early fibrinogen is key to the coagulation factor replacement. I think that a fibrinogen threshold of greater than 2 should be considered. Clotting screen and other things you have to be actually thinking about in a bit more detail. FFP transfusions may be beneficial if you give 10-15 bags of FFP because it's got fibrinogen in it. Okay. And there's no huge amount of data yet. I think that prothrombin complex concentrate might be considered better if you actually really want to actually give FFP, but there's some trials going on at the moment. Of course, the other big player is platelets, and I'll go through a couple of situations, urgent and planned surgery. There's new guideline on this, and I think I wanted to stress on some things which you may or may not be familiar. Of course, everybody will continue aspirin these days. I don't think anybody will stop it. With respect to elective surgery, you have to actually interrupt ticagrelor or clopidogrel for 5 days and prasugrel for 7 days. Now, I personally think that this has to be done a little bit differently. I think that you should actually see the patient and actually do this table. We had to use a bit more brain about, is this person with very high thrombotic risk, is this patient with very high bleeding risk, or is it somewhere in the middle? And this should be ideally done in the pre-op. I mean, so it could be for planned or it could be for urgent surgery. But obviously in the case of planned, it's a bit more easier. And I've actually got this, I've summarized from the guideline what people should do if you've got clopidogrel and ticagrelor, stop 5 days before, if the thrombotic risk is high and the bleeding risk is low, sorry, did I get that wrong? I think if the bleeding risk is high, then you have to stop long before, and the thrombotic risk is high, you actually tailor it down. So this is in the European Society of Cardiology guidelines on how to manage antiplatelet therapy before any cardiac surgery. But what you might sometimes come across is what to do when a person is actually in front of you and needs an urgent surgery in the next 24 hours. And Andreas Greinacher from Germany, I mean, they've done this work, which is preliminary, and I like it because what they've done here is that they've stopped the dual, I mean, bear in mind it's not prasugrel or ticagrelor, they've stopped these 2 drugs 24 hours before. They've given 2 bags of platelet concentrate, went ahead with the surgery, so theoretically the shock, the period of interruption of antiplatelets is very minimal. They're given 2 bags of platelets and went ahead with surgery, and we started the aspirin at 6 hours and dual platelets at 12 to 48 hours depending on the bleeding risk. So what they've tried to do is to keep the interruption of the dual antiplatelet to the minimum. And they found that there wasn't any excess bleeding and there was no thrombotic complications at all, which is interesting. So what I would do is actually, of course, if continue aspirin is pretty clear. If it's clopidogrel, I might suggest the Thachil protocol, the one I've just shown. Ticagrelor and prasugrel, I'll speak to the cardiologist and you guys and see, I mean, how good is it to give platelet transfusion, and actually how many do you give? I think this 2 is actually picked up from the air. I don't know whether it's actually really evidence-based, and of course our chair has actually published this fantastic work recently, and I think there is benefit of looking at a point-of-care test for platelet function, because many patients have different levels to which the platelets are inhibited, and it's completely wrong to say that everybody's actually had their platelets inhibited with the same drug with the same dose. It's baseless. So I think we have to be a bit more individualized. So we mentioned about other causes of bleeding, which is vessel wall and von Willebrand factor. And I think red cells also play a very important role, protamine, and something which I have to know about if someone might have had hemophilia, which can be diagnosed much later in life. And there are, you probably heard of aortic stenosis and acquired von Willebrand's disease, which can happen and they can hemorrhage. So this is up to me to deal with it, but somebody has to recognize that. One of my favorite slides shows how sad I am, but red cells float in the middle and pushes platelets to the side. So the red cells are lost, the platelets will drift into the middle. Very simple. So if a person is anemic, they will bleed more. And this has been shown in 1970s and 80s when they give iron to people, the bleeding actually got better. So when the person is anemic, there's something which you need to bear in mind, that the platelet function might be not as good as you would expect if they're anemic. Now, we use ACT as a measure to actually give protamine to reverse heparin. There's some work showing that if you get an overdose of protamine, that can actually cause bleeding. And the reason for that is because protamine inhibits factor 5 and factor 10, a couple of the clotting factors. And the suggestion now is that we should actually base the dose of protamine on heparin concentrations rather than the dose. Now that's also because what we do is we give the protamine based on a particular dose, and we don't know, well, of course, the ACT is normal, but we might be actually over-giving the protamine. To finish off, I've got something new I want to show you. This is from Thomas Rene's group. He's done phenomenal work on this. This is a new agent which blocks factor 12. Factor 12, one of the clotting factors. And what they've done here is that they looked at ECMO and capillary blockages, and they're given saline or heparin or the new agent. And you can see that the pressure gradient is actually completely inhibited by heparin and the new agent, as you would expect, as you can see there as well. But the most important thing with this study is that this agent did not cause any bleeding. So if you can actually have an agent which is as good as heparin, which does not cause bleeding, that's amazing. And I'll tell you the reason why, but this is, this actually shows, this is saline, this is the ECMO circuit, and actually you can see after a few hours there's been few platelet aggregates and clot formation, and this is when you're given heparin, and this is when you give the 5-7, the new drug, and you can see similar to heparin, it actually prevents any of the clot formation, and it actually seems even better. But sometimes I wonder when something looks, a new drug looks better than what is current. Well, there's a bit of tweaking going on, but anyway, I shouldn't say that. The reason why factor 12 works better is because factor 12 deficiency does not cause bleeding. The current thinking is that factor 12 is important in build-up of the thrombus. So once a thrombus is formed, if you actually need the thrombus to build up to the appropriate level, you need the factor 12. So it's been tried in ischemic stroke, because if you actually have the stroke and if you actually block the factor 12, then it will not build up to actually cause even worse outcome, but at the same time it will not cause any bleeding. So it looks a very interesting molecule. To summarize, red cells and fibrinogen are, I think, the crucial blood products. Platelet function assessment needs validation, but I think it's potentially very interesting on the horizon thing to actually look at. I haven't discussed antifibrinolytics and recombinant factor 7A. They got Mr. Gill and lots of talks earlier today going through this, so don't want to repeat that. I think thrombin generation, actually as a measure of how much clot is being generated, is a potential new test. We do this in our laboratory, but there is a group in Europe who actually is making point-of-care device for this, which I think will be potentially very interesting. And of course, that's from the diagnostic point of view. New agents, there are new agents which block factor 11, but then there's theoretical risk of bleeding. There's a place in Colindale in London, they're making heparin derivatives which does not cause bleeding. It's mainly for anti-cancer properties, but I would expect it to got anti-inflammatory properties as well. Last slide, I think we have to work together. I mean, I've been given a title called clotologist, which is a very minor role here. We've got fantastic people who are doing all the major work, but I think it's important that we talk to each other and work together, and it's very important. Thank you.